Hello, should we start?
Yes, Solix, you can take over. Thank you.
All right. I'm sorry, I'm going to use the audio. I'm not going to share the video. Hello, everyone. Good afternoon. Let me begin by introducing myself. My name is Felix Lalina. I'm a young emerging leader under Yale Initiative, supported by GNB Plus and Y Plus Global as well. I'm currently working as an administrator at Traza Live Initiative Uganda, and I'm based in Uganda. With much respect and honor, let me take this opportunity to welcome all of us in different categories who have managed to engage and participate in this meaningful session or advocacy webinar today, which is on you equals you. The undetectable equals to untransmittable, that is you equals you. This concept has fundamentally transformed by the global HIV landscape by empowering people living with HIV and challenging long-standing stigma. Basically, U equals U is underpinned by the science that persons living with HIV who reach an undetectable level of the virus through art cannot sexually transmit the virus. This has been an empowering concept, giving new hope and self-agency to people living with HIV, reducing stigma associated with the virus, and promoting public health through encouragement of testing, treatment, and adherence to antiviral therapy. Despite its profound impact on public perception and the lives of people living with HIV, the influence of U equals U on HIV criminalization and disclosure laws remains underexplored. HIV criminalization refers to the use of criminal law, the use of criminal law to prosecute people living with HIV for non-disclosure, exposure, or transmission of the virus. Transmission of the virus, often without consideration of actual risk or harm. These laws, which exist in various forms across the globe, have been criticized for being outdated, scientifically inaccurate, and counterproductive to public health goals. In many instances, the U equals U movement challenges the very underpinnings of these laws because under the new scientific evidence, PLHIV with for sexual transmission, they're living very slow to interrogate such new understandings. Hence, prostitutions remain considerably out of step with current scientific knowledge. Moreover, legal and ethical considerations outside of sexual transmission, for example, vertical transmission, injecting drug use, the role of U equals U, internalized stigma have barely been explored. I think that is the background of our session today. Without wasting time, let me pass it over to our moderators of the session today. Enoch and Wabantu. Wilson, can you take over, please?
Hello, everyone. Greetings to you. I hope I'm being audible. Am I audible?
Yes, a bit.
All right. My name is Dr. Topelo and I'm a Master of Public Health student from Zimbabwe and also a young emerging leader. Thank you very much, Felix, for a bright and also an informative introduction on our webinar that we're going to be having today on youth equals to you, which is we want to try by all means to unpack the misconceptions, or rather, we also want to educate ourselves on how this undetectable equal to untransmissible webinar that we're going to be having on HIV and AIDS. And today, my task is very simple. I'll be one of the moderators. I'll take the last segment. The first segment will be taken over by my partner, Enoch. But as for the rest of the segment, if you have got any question or anything that is burning, please do take time, and also please do type in the chat box there, or you can address the messages to my inbox, each and every question that you have or that you feel like you need to ask or that is burning to you. Then after we're done with that, I'll then take over and ask questions to our beloved speakers, at the same time to each and everyone as well to take part. Otherwise, I hope we're going to enjoy and we're going to learn as well. Thank you very much. Over to you, Enoch.
Okay. Hello, everyone. Thank you, Dr. Wilson, and thank you, Felix, for this introduction. My name is Enoch Simeonkra. I'm based in Cote d'Ivoire, and today my task is to co-moderate this session with Dr. Wilson. So without waiting any time, let's introduce our speakers today. So we are going with Elliot.
Hello,
Can you hear me? Can you hear me?
Yes, thank you, Enoch. Thank you for inviting me today. I guess I'll just give a brief introduction to myself. I'm a UK-based legal researcher, and I work as a policy analyst with the HIV Justice Network, which is a community-led NGO seeking to build a coordinated and effective global response to challenge punitive laws which target people living with HIV. So I'm looking forward to speaking to you all today.
Okay, thank you, Elliot. Let's move on to Sibongile. Sibongile, please introduce yourself to our attendees.
Thank you so much. I am Dr. Sibongile Kubeka, and I'm based in South Africa. I am the Regional Medical Director for ViiV Healthcare, and I head up medical affairs for the Africa region. And I am truly honored to have been invited to speak on such an important topic. And thank you for bringing this topic to this webinar. And hopefully we can, in partnership, make sure that we get the conversations going on this important topic. Thank you.
Thank you, Sibongile. Over to you, Emmanuel, please.
Hello, everyone. Good morning. My name is Emmanuel Owen. I am based here in the United States. I am a biomedical scientist and also a public health researcher. I work at the intersection of human rights, queer rights most especially, and also sexual and reproductive health and rights, and democracy and governance for young people. And the major focus of our work is to amplify the voices of underrepresented communities, the LGBTQI communities, the people who use and inject drugs, and also sex workers communities, and to ensure that their voices are amplified and their needs are also captured in policies that are being made towards progressive governance. Thank you, and I'm really excited to be here.
Thank you, everyone, for introducing yourself. Please, is there any? Okay. Yeah, I think we are moving on. Yeah, Patricia. Okay, yeah, Patricia. Sorry, I was looking for you. So yeah, please go ahead, Patricia. Hello, Patricia, we can hear you.
My name is Patricia Acero. My name is Patricia Acero. Can you hear me now?
Yes, we can hear you. Please go ahead.
My name is Patricia Acero. I'm the director of the Renga Women Fighting AIDS Group, and also the chair of the International Community of Women Living with HIV, the Kenya chapter. I'm a treatment activist, very passionate about access to treatment, but also advocate for sexual reproductive health rights for women in all our diversities. So I'm glad to be here, and thank you for the invitation.
Thank you, Patricia. So now, as we have introduced our speakers, we are getting started with the webinar. So we firstly go with a presentation from Elliot that is gonna take us through the HIV criminalization laws. And yeah, please, Elliot, please go ahead. Please, you have over to you.
Yeah, Catherine, could you make the presentation full screen so we don't see the notes, please? I think down the bottom, there is an icon, a square icon. Yeah, that's the one. Great, thank you. So yes, I've been asked to give a presentation today on HIV criminalisation, and what we mean by that is the use of criminal laws to prosecute alleged HIV exposure, non-disclosure and transmission. I think as we're talking today about U=U science in particular, it's important to understand what the current status quo is in regards to the use of criminal laws in this context. I think when we examine how the laws are used, we can see that there's quite a big gap between U=U science and how laws are currently implemented. So if we look at the types of criminalizing law, HIV justice breaks down criminal laws concerning HIV criminalization into a few categories. Most obviously is HIV specific criminal laws. So these are laws which target HIV specifically, either by only criminalizing HIV or by singling out HIV for greater punishment as compared with other conditions. And we monitor whether these laws are enforced or not enforced to give us an idea of the extent to which these laws are being used in practice. We also monitor what we call, sorry, I'm seeing a request to speak slower, so I will try to do that. So we also monitor general disease laws. So these are laws which target diseases generally. They can be framed to include all diseases or to only include sexually transmitted diseases. And HIV may be included in these laws explicitly alongside other diseases, or there may in fact be no specific references to any conditions. It may just be a general blanket criminalization of diseases or infections broadly. We also track general criminal laws. So these are laws targeting the infliction of harm or injury, for instance, assault laws. And in some instances may also include sexual assault laws, where non-disclosure of HIV status is treated as sexual assault. For example, we see that in Canada. And these types of laws exist in every single penal code in every country. And that's not something that's going to be removed from criminal legislation, but we can certainly try to limit their application in HIV cases. And then we also have a general category, which we called other law. So this is sentence enhancement provisions, for example, sexual assault provisions, which may impose higher penalties where the person accused is living with HIV, and also other types of laws, such as public health laws, which don't include criminal penalties. So we can go to the next slide, and we can see that there are 3 broad categories of criminalisation which we monitor. So that's alleged exposure, non-disclosure, and transmission. However, it is important to say that laws are often framed in very broad and vague terms, and the lines between these categories may be blurred in some instances. And laws may be framed in a way which targets specific conduct, or again, they may be drafted in broad terms and have an open-ended framework which can be applied in any kind of situation. But these are the general patterns of conduct that we see criminalized. So most obviously is sexual activity, but beyond that, non-sexual routes of alleged exposure or transmission are also seen in cases of spitting, biting, sharing needles and syringes, blood or organ donation, and related to that with non-disclosure of HIV status or previous sexual experience during a donation, breastfeeding or vertical transmission, and medical negligence. And as you'll probably be very aware, many of these situations do not carry any meaningful risk of HIV transmission. However, we still see criminal laws applied often in these situations. So we can move on to the next slide. So when we actually look at how these laws are enforced in practice, we can see that the situation varies. So according to the data that we most recently reviewed, which was in June 2024, we see that around 1/3 of jurisdictions in countries have punitive HIV-specific laws in place. So that's 104 jurisdictions in 79 countries. Of these, around half have ever enforced their laws. So that means around half of jurisdictions have HIV-specific laws in the books which have never been used in a single case concerning alleged HIV exposure, non-disclosure, or transmission, which demonstrates that in many instances, these laws are totally unnecessary. I should also say at this point that our data relies quite heavily on media reporting, which we recognize has inherent limitations. So some cases may not come through normal routes of media reporting. But nonetheless, the data shows that criminalization is a significant problem. It also shows that HIV criminalization is a problem beyond just HIV-specific laws, because we see that there are 163 jurisdictions in 92 countries which have ever reported HIV cases under any criminal law. So that demonstrates that the problem extends beyond HIV-specific criminal laws. And when we look at recent enforcement, which we define as since 2019, we see that more than half of these countries have enforced their laws. So it's an ongoing active issue, not a historic challenge, an ongoing challenge that we must face. So we can move on to the next slide now. So this just gives us a visual representation of HIV criminalisation across the world. I should note that this map was created in February 2023. So there have been some changes since this map was created, but it gives us an idea of the global spread of HIV criminalisation. And as you can see, HIV criminalisation exists in every region of the world. We can see from the blue on the map that HIV-specific criminal laws are more prevalent in some regions, for instance, Eastern Europe and Central Asia, Western and Central Africa, and Asia Pacific. But as the purple on the map demonstrates, even when there are no HIV-specific laws in place, we still see widespread application of general criminal laws to HIV cases. For example, in the Americas and Western and Central Europe and Oceania. So while it is essential to tackle the issue of HIV-specific criminal laws, the issue goes beyond that. Okay, we can move on to the next slide. And so when we dig down into the data, we can see what kinds of groups of people are being targeted by HIV laws. So our June 2024 analysis of the preceding 5.5 years found that in over half of HIV cases, the defendants were men. Around 80% of these were men who have sex with women, with the remainder being men who have sex with men, although there are some cases where the activity in question is not related to sexual activity. Cis women make up around 1/4 of defendants. But this is a global picture because the trends vary by region. So when we analyze all cases that we have ever recorded, we can see that in some regions, different groups of people are targeted at different rates. For instance, in Eastern and Southern Africa, we see that women make up around half of defendants. In West and Central Africa, we see that sex workers make up around 1/3 of defendants, which is significantly above the global rates. In Middle East and North Africa, migrants make up around 1/3 of defendants, again, significantly above the global rate. And in both Asia Pacific and Oceania, gay men are the largest demographic of defendants. So while it's useful to see the global trends, it's clear that the laws are enforced against different people in different regions. So let's move on to the next slide. And so the question I think we can ask is criminalization ever appropriate? I think as a starting point, it's important to say that HIV should be treated as a public health matter, not a criminal matter. And that's because we know that criminalization is an inappropriate tool for the protection of public health. There is no evidence that suggests that HIV criminalization protects public health. In fact, there's significant evidence to suggest the opposite, as criminalization, especially through the use of HIV-specific laws, creates a barrier to accessing healthcare, furthers stigma around HIV, and discriminates against people living with HIV and key populations. So HIV-specific laws have no place in modern criminalization. Many of these laws were adopted some years ago and are based on outdated and misinformed notions of transmission risks. HIV laws are not caught up with updated HIV science, for instance, in regards to the science on U=U. So we should aim to limit HIV criminalization as much as we can. So to do that, we need to repeal HIV-specific laws and only apply HIV cases in very limited circumstances, and then only under general criminal laws. So UNAIDS has been clear now for quite some time that HIV cases might only be appropriate in very limited circumstances. And those are where there are 3 elements that are met. So that is when a person living with HIV knows their HIV status, acts with an intention to transmit HIV, and transmission actually occurs as a result of their conduct. We know that these elements are only satisfied in a very small number of cases that we see reported. So there is great potential for limiting criminalization if this policy platform was applied. Okay, moving on. I've included here a couple of examples of laws, HIV-specific laws, which give us an idea of the range of laws that exist. I think it's important to say, first of all, that when it comes to what is a good HIV law, the answer is one which doesn't exist, because as we've said, HIV-specific laws really do have no place in modern criminal legislation. And there are some countries who have repealed the HIV-specific criminal laws and have introduced policy guidance which limits criminalization to the kinds of conduct that UNAIDS recommends, which is the ideal scenario. We've seen that in countries like the Netherlands, Switzerland, Austria, but there's still much more potential for improving the law. So just briefly touching on these 2 examples here. In the law in Congo, we see that it's framed in relation to criminalizing intentional transmission, which does align with UNAIDS policy. And the law also has a number of important safeguards against prosecution built into it. I won't go through all of those, but it's important to say that what's not included as an explicit defence in cases of alleged HIV transmission is cases where the person living with HIV has attained an undetectable viral load, which would align with the science on U equals U. This is perhaps because this law was passed in 2011, potentially a little bit before widespread understanding, at least in a legal sphere, of U equals U science. So there's certainly room for improvement there, but it's got some important safeguards. If we compare that to the law in Lesotho, this is quite a problematic law for a number of reasons. For one thing, having sex while living with an STI is defined as coercive behavior. And some STIs, which would include HIV, are categorized as life-threatening, which we know with access to medication is no longer the case. The law also requires anyone charged with a penetrative sexual assault to have their blood taken and tested for HIV, with the results used in evidence for sentencing. The law also previously imposed the death penalty where the accused was aware that they were living with HIV. However, thankfully, this element was ruled unconstitutional in 2022. Okay, moving on to the penultimate slide. I think it's important to highlight some positive trends because often the legal landscape can feel anything but positive, but there has been some good movement in regards to law reform in recent years. We have seen, as a result of sustained advocacy by civil society, a reduction in the number of HIV-specific laws in place around the world. We've also seen a reduction in the numbers of HIV cases being reported. They've dropped by around half since the onset of the COVID-19 pandemic. However, it is important to exercise some caution with these numbers because it is possible that the media is merely underreporting on HIV cases as compared to before the pandemic. And we've also seen an increase in the use of modern HIV science in laws and in cases. Defense cases are able to rely on this science to successfully defend against prosecution. We've seen that being implemented in more and more cases in more and more countries. So that's a really positive trend. And then finally, if anyone would like to learn more about HIV criminalisation, I would just point you to the HIV Justice Network website, where we host the global HIV criminalisation database, which records all laws that we're aware of that relate to HIV criminalisation in every country in the world, and all cases that we become aware of. We also have a newsletter, HIV Justice News, which you can subscribe to get regular updates on HIV criminalisation. And we have the HIV Justice Academy, which is a global learning and resource hub for beginners all the way through to experts, and it's designed to help individuals become part of the movement to end HIV criminalisation. And that academy is available in 4 languages. So I will wrap up my presentation there. Thank you very much for sharing the slides, Catherine.
So thank you, Elliot, for this presentation. Thanks to that, we have been grounded into this legal framework. Now we are more aware of the HIV criminalization, the laws that are used to criminalize HIV. So now we can step in on the U equals U concept with a presentation from Sibongile. So Sibongile, please, you can go ahead with your presentation.
I'd love to see the presentation, please.
Catherine, please, can you?
There we are. Great, thank you so much. I've been asked to talk about breaking the science. So let's simplify the discussion around what does undetectable equals untransmissible mean, and how does it translate to not only the people living with HIV, but also those who are their partners who may be HIV negative. So when we start by tackling the science, let's start with the basics. What is an undetectable viral load? So I'll get back to what the WHO statement stated in 2023. So an undetectable viral load is really the ultimate goal for everyone living with HIV who is on antiretroviral treatment for their own health and to also prevent onward transmission to their sexual partners and also preventing mother-to-child transmission. So in essence, an undetectable level of HIV in the blood is the ultimate treatment goal that everyone should be aiming for who is living with HIV and on antiretrovirals. So the question then is, how do we get there? Simplifying viral suppression explanation. Viral suppression refers to the amount of virus that is assessed in the body. And it's typically measured by viral load testing. And I've put here two references in terms of what it is that they have used before, and I'll explain why I've put two. So according to the Center for Disease Control, CDC, it defines viral suppression at less than 200 copies per mil, whereas UNAIDS has previously, at the time of the publication, it was less than 1,000. But I just want to highlight that this has advanced a lot over the years. And it's almost like zooming in to say, how close can we look to actually make sure that we don't pick up any virus that we're assessing the plasma. So it's gone from less than 1,000 copies to less than 400 copies to less than 200 copies. And as it currently stands, some countries are implementing less than 50 copies per mil, which is actually quite great progress when we're trying to define what viral suppression is. So viral suppression is often used interchangeably with undetectable. And we will then just go into explaining how this goes about. Can we move to the next slide, please? So just breaking it down, when we say someone is virologically unsuppressed, that means that in the blood sample that has been taken when they're measuring the mRNA on plasma, they have got more than 1,000 copies of viral mRNA that is being detected. So what does that mean? That means there's significant virus that's replicating and that is present in the bloodstream. And what does that translate to? It means that the person has increased risk of falling sick and of transmitting the virus to their sexual partners through use of injectables. And also mother-to-child transmission is at high risk through giving birth and through breastfeeding when your viral load is greater than 1,000 copies per mil. Then we move to suppressed. Suppressed is an interesting one because suppressed says it's less than 1,000 copies per mil. Not zoomed in quite clearly, but it's less than 1,000 copies per mil. So what does that mean? So what that means that there is some replication of the virus that is taking place. And this could be due to not adhering to treatment properly, maybe not taking your treatment consistently. And what does that mean for your partners or your children? It means an almost zero or negligible risk of transmission of HIV to your partner. Now, when I look at this, I always say the almost part is the red flag here. So almost is the red flag in saying you are not at a point where you are fully comfortable in the U equals U. However, it is still somewhat an acceptable level. But what this says is that if you are given a result that says less than 1,000 copies per mil and you have the opportunity to actually zoom in better, that is what I would recommend. But also, if you are at less than 1,000 copies per mil, and as you zoom into, let's say, less than 200, and in some is detected, then I think you need to go back and look at what your treatment currently is at. Have you developed some drug resistance? And are you in a situation where you may have gotten some mutations that need to be attended to? The ultimate goal is undetectable. So currently undetectable is less than 200 copies per mil. So when you get to undetectable literally means that there is no measurable virus in the blood sample or whatever sample that has been used to look at your viral load. And this translates to zero risk of transmission to your sexual partner, and also zero risk of transmission to pregnant mothers during birth and breastfeeding. So as I said, the ultimate goal is to get to a status where you reach and you sustain undetectable viral load. Next slide, please. So how did we get here? I'm going to give you a background of 4 clinical studies, taking into account that there is a lot more in terms of clinical data that's available. So the 4 clinical studies that I want to share with you have a lot in common. That's why I wanted to summarize the 4 together. The 4 are the HIV Prevention Trial Network 052 study, Partners of People on ART and New Evolution of Risks, that was the partner study, Opposites Attract, and the Partner 2 study. The key outcome of these studies is that they demonstrated the effectiveness of antiretrovirals for preventing sexual transmission of HIV. So if we summarize what it is that we found from these studies, what we found from these studies is that all the studies that I've mentioned above, as I have just explained, viral load suppression and all. So from all the studies that I've mentioned above, they followed HIV serodiscordant or serodifferent couples, meaning that one partner is seropositive, HIV positive, and they're already on antiretroviral treatment, and they're virologically suppressed. And the one partner is seronegative, and that means that when they take an HIV test, they're HIV negative. And in all the tests, the viral suppression was defined as less than 200 copies per mil. And it was only the HPTN 052 study that used less than 400 copies per mil. Next slide, please. So when we followed up with these studies, the follow-up and the assessments of these studies required that there's regular viral load testing of the partner that is on antiretroviral treatment, and there's also regular HIV testing of the partner who's HIV negative. Now, interestingly, from these studies, they counted the numbers of sexual acts that had taken place. The studies showed that there were 123,888 sexual acts that were conducted or happened without pre-exposure prophylaxis or use of condom. Now, what does that tell us? It says that the findings from these studies provide scientific proof that undetectable viral load reached when your HIV medication, you are adherent to it, it actually translates to untransmissible viral load. And there's a new phrase that is very much key now, and that is treatment as prevention. So when we're looking at use of condoms, we're looking at use of pre-exposure prophylaxis. Actually, antiretrovirals that are taken by patients who are on treatment, that translates to treatment as prevention, which is a key strategy when we're looking at U equals U. So treatment as prevention is just a biological approach for HIV prevention that includes the use of antiretrovirals to suppress the viral load in people living with HIV, to suppress it to such a point that there is zero risk of transmission, whether it's through sexual transmission that you were thinking about, use of injector needles, or whether it's mother-to-child transmission. Next slide, please. So when we're looking at the messaging behind U equals U, U equals U aims to communicate that the scientific evidence is very clear that when an individual gets to a point where they are virologically undetectable and they maintain an undetectable viral load, they cannot transmit HIV sexually. So this helps in combating this HIV-related stigma that we're dealing with, and also supports people living with HIV to live a healthy and fulfilling sexual relationships with their partners. Getting and keeping an undetectable viral load is really the key in saying, how do we ensure that in translating U equals U, there is uptake, and as we understand the law, there is responsibility taken by both partners in understanding the importance of U equals U, especially the person taking antiretrovirals. So I've shared with you 4 key studies that have supported the U equals U, but there's more studies, and here, the one that I wanted to share with you, it was a systematic review of 72 studies that found that interventions, when implemented, that disseminate the U equals U information and the uptake thereof of the need for rolling out U equals U, what the results are and the impact thereof. The impact thereof is HIV testing, adherence, and viral suppression are increased. Stigma is reduced, and it's reduced without leading to an increase in the incidence of sexually transmitted infections. Can we move to the next slide, please? So in conclusion, when we're looking at this from an individual's point of view, as well as the role of the community, when we increase the uptake of U equals U at an individual level, what does that translate to? So at an individual level, if we increase this uptake and education around U equals U, we see an increase in the uptake of HIV testing services. More and more people come forward and they want to test their HIV status, which is a good thing, because it literally addresses one of the 95 pillars that we're aiming to achieve. It improves treatment adherence and achievement of viral suppression. So if you want to achieve a point where you are undetectable, it allows you to have a healthy sexual relationship, and it also minimizes the stigma of HIV. And what is more important is an undetectable viral load improves the quality of life and the well-being of people living with HIV. And these are just but a few of the pros of ensuring that if we can literally get the message across of the importance of U equals U scientifically, we can get somewhere in achieving the 95-95 goals and even actually eliminating HIV transmission. So at a community level and at an organizational level, what does it mean when we look at the science of U equals U?
Eu perdi a
When we look
conexão,
at the
então não consegui. Só consegui até agora entrar na ligação.
Okay, I'll be quick.
Então,
So
agora falando das conclusões.
all right, thanks. So at a community level, what is really key
No
is
nível da comunidade.
what is happening. I think someone's unmuted. All right, I'll try and continue. So at a community level, what does this mean if we really take on the U equals U? It means that if we take it upon at a community level and at the partnership level, we can improve the HIV literacy around U equals U. We can increase health equity by championing universal access care and the treatment thereof, and also reduce HIV-related stigma and discrimination. And as I get to the last slide, next slide, please. This slide, I wanted to conclude in terms of what are the challenges that we're facing. The science supports this. The science is clear. And the even organizations, whether you're looking at WHO, UNAIDS, it is clear that U equals U is a fully understood scientific evidence-based knowledge. But where are we finding the challenges there? First one is lack of education and awareness about U equals U among key populations, healthcare workers, and the general public. And I do want to highlight the healthcare workers because it is really sad that we find ourselves in a situation where the U equals U, lack of awareness and understanding thereof, triggers it and filters down to stigma in the healthcare setting. We also find limited understanding of the implementation of U equals U as an intervention, as well as the benefits thereof. And this also requires some resourcing and understanding in the education of people in the community thereof. There's lack of resources, specifically funding and the technical expertise to implement, scale, monitor, and evaluate. And one of the experiences that I've come to, become very much aware of is that it's not every setting that allows access to viral load testing, which is a challenge to our healthcare settings to try and increase the resourcing and the testing thereof. And lastly, in some settings, there is also an unwillingness to share the message of U equals U. And that's because of the stigma and the judgmental views thereof. And I think in partnership with healthcare providers, in partnership with government, in partnership with the legal advocates, and all other community advocates, all of these need to be addressed. And I just wanted to end with a quote that I really liked, and that's from Helena Nangove, and it says, the world and people living with HIV need to know about the concept of U equals U and the wonders that ARV is doing. People living with HIV, we are not a danger to anyone. We need to work together to spread the correct information and to end the stigma against people living with HIV. Thank you, Enoch.
Thank you, Dr. Sibongile, for this presentation. I think it is a great presentation, very, very insightful presentation. With what we have learned from the HIV criminalization given by Elliot, plus yours, I think we are more aware about the impact that U equals U can have on HIV criminalization and disclosure. So now, before we move on, I would like to invite all of our attendees to please feel free to drop your questions, your concerns into the Q&As. So now we are moving on to the next step, that we're gonna have a roundtable, and then we're gonna discuss some questions to in order to delve deep in the topic. So I would like to, Dr. Wilson, are you there? My co-moderator. Okay. I think they're not there, so okay. Not easy, the Portuguese translation. Yeah, someone I have to bring you back to.
Yes, hi, Emmanuel, you can go ahead.
Okay, I don't know. Would you like to take it from here, or can I keep going?
You can continue.
Okay. So we have some questions to ask to our speakers. The first one is, how does the scientific evidence supporting U equals U specifically apply to sexual transmission? And is there research that support its applicability to other transmission routes, such as vertical transmission and injecting drug use? And this question is addressing to Sibongile, Dr. Sibongile.
Okay. Thank you so much for the question. One of the things that requires an individual to get to U equals U, it is an understanding of their HIV status. It's an understanding of the importance of healthy sexual behavior. And it's also an understanding of the importance of adhering to treatment. So part of the research in terms of what it does and the systemic review, what it does is it takes an individual through the journey of understanding what HIV means and translating it into how healthy living is then, what healthy living means for a person living with HIV. So if you have got someone who uses drugs for injections, and let's say someone who is at risk for acquiring sexually transmitted infections, the questions that would have reached scientific evidence that I shared with the 72 systematic reviews is that the individuals need to get educated and be aware and consciously know the importance of what healthy sexual lifestyle means. And that translates to use of drugs, and translates to use of, it translates to sexually transmitted infections. And that's the added benefit of U equals U, in that once you get to a person to a state of understanding the importance of U equals U, that individual understands what it means for quality of life, healthy and improved sexual lifestyle. And also, what is more important is it pushes the narrative towards saying, let's make HIV a small part of people's lives. So when you get to that level, HIV becomes a small part of people's lives, and it triggers and filters onto saying sexually transmitted infections then become a small part of people's lives because it's an awareness of the behavior. Use of needles, you become less of a problem because now my blood has got no, it's undetectable virus. I hope I've answered that.
Yes, totally, please. And we have a second question that is, this one is for you both, Sibongile and Elliot. We would like to know, are there any gaps in the scientific evidence regarding the effectiveness of U equals U in preventing transmission through non-sexual routes that could impact its legal implication? So the question is for you both, Sibongile and Elliot, please.
Elliot, do you want to start and I'll take after you?
Yeah, I mean, I can't speak to the gaps in the scientific evidence, as that's not my specialty. I would suppose I would say from the legal perspective, whilst it's extremely important to have a good understanding of the scientific evidence around HIV transmission routes, and that includes U equals U evidence. Unfortunately, what we see, and I obviously touched on this in my presentation, is that far too many of the laws that exist are not based on HIV science, even science that has been established for quite some time. So, for example, laws which make it a criminal offence for someone living with HIV to spit on somebody, it's been well established for a very long time that spitting is not a route of HIV transmission, and yet the laws have not been changed to reflect that evidence. So while we should welcome any and all scientific evidence, including the evidence on U=U science, I think when it comes to its legal implications, I think the problems are often the speed at which the laws actually implement that science. And I think that's an issue that needs to be addressed in lots of different ways. But it is certainly a big challenge. Yeah, I think that's what I would flag at this point.
Yeah, thanks. From my side, I would take it, I'm not a law expert, but if I was to be sitting and giving an opinion, legal opinion, I would say if a person has taken the initiative to know their HIV status, has not only achieved virological suppression, but maintained it, then that person has shown a lot of responsibility and accountability in terms of ensuring that they're protecting their sexual partner. Now, if the person, and we switch it around, is negligent in that they know their HIV status, they are not taking their medication as they should, and they're not getting their viral load monitored, I would think from a legal perspective, that is a cause for concern. But if we take U=U as it is scientifically proven, where someone is adherent to treatment, virologically suppressed, undetectable, untransmissible, then in all essence, I think it would be very much good to get the legal, experts to challenge whether is it fair to expect someone to be prosecuted just for being HIV positive if their status is literally undetectable.
Yeah, for sure. Thank you. So for the purpose of time, we move on to the next question. The next question is specifically addressed to Elliot. Elliot, we're interested in knowing what legal or policy barriers hinder the full adoption of U=U principles in HIV criminalization laws, and what can be learned from jurisdictions where U=U has been successfully used as a defense to improve its legal recognition. Please.
Yes, well, I think Sibongile touched on some of the barriers to a widespread understanding of U=U principles, at least in her presentation. I suppose as it relates to the wider legal and political barriers, I think there are a number. I think I touched on one a little bit in my previous answer. The pace of change can often be very, very slow when it comes to legislative reform. And we've seen, even when legislative reform has been achieved in relation to HIV criminal laws, for example, there was a recent reform in Argentina, can take many, many years. That reform took over a decade, despite incredible work by a broad coalition of advocates. So the pace of change can be a huge barrier to implementing latest science. I think the science often moves quicker than the law is willing to do. And I think a big part of that is also to do with political appetite. I think because of ingrained stigma and misinformation around HIV, politicians often believe that reforming laws around HIV criminalisation would be a politically unpopular thing to do, but that's based on misinformation, because the evidence is so clear that HIV criminalisation is actually more harmful to public health and increases rates of transmission. So I think if politicians are able to understand that evidence, then we can actually see the changes that need to be made. And I think that's the job of advocates. It's the job of experts in the field to lay out the science in as accessible form as possible. And it's the job ultimately of policymakers to actually listen to the evidence and to implement that in the laws that they are adopting. Unfortunately, it often takes too long to get there, but we are seeing improvements. I specifically point to the expert consensus statement on HIV science as it applies to HIV criminalisation, which was a statement agreed by 20 leading scientists in 2018. And that's had a real big impact in, particularly in court cases related to HIV criminalisation. There's been a number of cases that have been able to point to that statement as evidence to prove that in the particular circumstances of the case in question, transmission was not possible because of the U=U science and because of the other protections that can be taken against transmission. So having clear policy and scientific evidence to point to in specific criminal cases is hugely important to be able to defend against overly broad criminalisation.
Okay, thank you, Eliot. We have a fourth question. That one is addressed to Patricia, finally, to Patricia and Emmanuel. So Emmanuel and Patricia, please, how can U=U be effectively communicated to pregnant women and people who inject drugs to prevent vertical transmission and reduce harm?
So I think what
Emmanuel and Patricia.
I also see the same question. There's Iris, I think, who's answered, and I'm going to try my best to explain it. So when we're talking about U=U, U=U is taken from the understanding of what undetectable means. So undetectable is the understanding that there is no viral activity, viral replication taking place in the blood, in the serum, in the sexual fluids, in the breast milk. There is no viral replication that is detectable. Now, what does that mean when I say undetectable? It means through sexual interaction, undetectable equals untransmissible. When giving birth as a mother and you are undetectable, you are preventing mother-to-child transmission because you are undetectable in terms of there's no viral replication, viral activity taking place. It is suppressed. When you are injecting blood, let's say you are using drugs and you're injecting blood, and that's the one that I'm hoping it will stop, but when you are injecting blood, let's take it this way. When you were tested for your viral load, it was taken from your blood, right? So a blood sample was taken, and the blood sample showed undetectable, which means no viral activity, no viral replication, no viral presence found, meaning that needle users are also very likely at the point of being undetectable to be untransmissible. So when we say undetectable equals untransmissible, that has been translated to sexual activity, prevention of mother-to-child transmission, as well as use of needles, sharing of needles. I hope I've answered it.
Yes, yes. But I don't know if Emmanuel would like to add something.
Hi. Hello, everyone. Thank you. It's been an exciting, interesting conversation that I've been enjoying myself all this while. So I would just like to build up on what Sibongile said. Untransmittable equals undetectable equals untransmittable means you cannot transmit the virus no matter how expose or how you expose your sexual partner. If you use a needle, if you got accidental needle prick or you're injecting drugs and all of that, provided that there is no biological viral activity in your blood, that means that what's happening? Confirm you're speaking language, English, yeah. So I'm sorry about that. So provided that there's no activity in your blood, that means the viral load is not detectable at all. That means you cannot transmit it. But sometimes people confuse being undetectable and not being able to transmit the virus as to being completely cured from having HIV. That's not what it means. The virus is still in your system, but not within detectable limits. The virus might be dormant because your medication is not letting it replicate the way it usually replicates. So they are sent off to sanctuary sites, places in the body that have no connection with the bloodstream. And that's where they remain dormant for a very long time until maybe you stop taking your ARVs and they start popping out again. I don't know if you understand, if that explanation makes any better sense to you. Now, to your question on
better.
To your question on how we can effectively communicate U equals U message to pregnant women and people who use drugs. I come from Nigeria and I come from rural community, and I have an understanding of for pregnant women, there is something called prenatal care and postnatal care. So during this prenatal care, pregnant women get first-hand medical services from their healthcare providers to guide them on how they can manage the pregnancy from the first trimester, second trimester, up to the time for delivery. So I think it is important that we incorporate the message of U equals U during the prenatal care of this pregnant women. Let me not use mothers because they're not giving birth at the time. So if we incorporate these messages during the prenatal care, they are able to really communicate with their healthcare providers about this message and also allay any concerns that they may have about it. Also, it is important for us to also train our healthcare professionals, most especially those ones in the grassroots, on how to effectively communicate the science of U equals U. Because most people, you tell them this, they will still have their speculations or, their reservations about what you're telling them. So providing adequate training to healthcare professionals as well can also be very, very beneficial for us. Also, for people who use drugs, we can incorporate messages about U equals U in programs such as harm reduction programs, needle exchange programs that the community of people who use drugs do from time to time. We can incorporate these messages about U equals U during these programs. And the fact that I am undetectable, my love, it is interesting and also exciting to know that I cannot transmit the virus. So if you bring such an exciting conversation to our support group meeting, I will be very much excited to learn more about it. So incorporating these messages down to peer support levels will be very important in helping us navigate communicating effectively and also helping more people to learn and know more about U equals U. Thank you very much.
Yeah, thank you, Emmanuel. I think you.
Can I go?
You said it all, but we would like to listen to Patricia.
Enoch, may I just
Patricia
quickly
here?
just add one thing?
Patricia here.
Patricia?
Hi. Yes?
Please go ahead. Would you like to add something?
I would just like to chip in. Can I be heard? Can I be heard?
Yes. Patricia, we are hearing you, dear.
Yeah.
Yes, I would like to chip in that we need to use the community instruments. We need to use the community instruments to be able to pass the messaging about U is equal to to pregnant women, not just to the ones who are already pregnant, but the ones who are even thinking about pregnancy. So what are those modalities that we have in place? One is the treatment literacy sessions that we have, that we improve the treatment literacy materials that we have within our different countries, so that when people are going through the treatment literacy materials, then U is equals to U science is one of the topics that is discussed. The other component is the information that is given at the clinic every day. Those talks, health talks that are given at the facility. That one of the talks that needs to be going out right now at the health facility is the U is equals to U science. The other aspect is the support groups. When women are at their different support groups or they're having their community dialogues, that one of the sessions be U is equals to U. In Africa, we speak a diverse of languages, so that if this information can be broken down to our languages so that people are able to grasp exactly what we are talking about. Because sometimes when you speak this in English, how it will, you translate it into Swahili, then how you got it into my mother tongue, whether I'm Luo, I'm from Kenya, how do you translate that information effectively to the mother or to the young person you are talking to? Are you able maybe to speak it in slang if they are speaking slang that they understand well? We have what we call in Kenya is called Sheng. Are you able to bring it down to that level? The peers who are working at the different levels with the different groups are supposed to be well trained on this so that they are able to pass the messages to the women. And then the people in the facility, especially at the antenatal clinic, need to be well informed so that when these women have questions, then they are able to answer to those questions. So that is what I want to bring in because it has been discussed broadly. Back to you, dear.
Thank you so much. We have the next question may be a bit similar to was one you have already answered to, but we would like to ask, what social barriers prevent the widespread acceptance of U equals U principles, and how can these be overcome to reduce stigma and improve understanding in communities affected by HIV? That is to Patricia and Emmanuel. So Patricia and Emmanuel, please go ahead.
Can you come again with the question?
The question, okay, please. The question is, what social barriers prevent the widespread acceptance of U equals U principles, and how can these be overcome to reduce stigma and improve understanding in communities affected by HIV? Social barriers that prevent the widespread acceptance of U equals U principles, and how can this be overcome to reduce stigma and improve understanding in communities affected by HIV?
So this Patricia.
Yeah, Patricia.
One area that we have to be able to bring it in is our treatment guidelines. It is within the guidelines. Once a country is able to accept that this is a science that is approved and acceptable, that is our first step, that our countries are able to bring these out as one of the science that is acceptable. And it is rolled out in a national-wide intervention, like now what is going on in Kenya. We have a team that is working around U is equals to U. We are looking at the language that we are using as a country and which is acceptable to everybody. All stakeholders are involved at the stakeholders meeting so that it is something that can be rolled out once people are agreed on it, so it can be rolled out across. So those are the barriers. If people working in the government do not accept that science, then that is a barrier. If the language that is being used is not acceptable to the people, that would be a barrier. Then the medium that is being used, like now, the social media is one component that we never had before. When we were starting to do advocacy as young people, we didn't have social media, but that is now something that is dear to the young people. So using everything available to break the barriers, to make this information more accessible. It should not just be a one-off session, like now we're having a session. Is it going to be a one-off session that we just talk about and then off it goes? Or is it something that we can be able to build so that it has a momentum and everybody understands it. The way we're talking about COVID is about COVID, it's about washing hands, it's about keeping distance, so that it was ingrained in people. So at this level, we also need to be able to work and make people understand, so that it's like harming and harming and harming until it gets in. Because the science is new to some people it's not new. For us, we knew about that treatment works and the treatment is prevention. So when it has come to the level of U is equals to U, we are building on the momentum that we had before. But the people who are not HIV positive might start thinking that this is a new way we want to portray ourselves, or we want maybe we still want to pass on the information, but the infection. But if we can be able to work hard by giving information and not just stopping at once, giving it from different levels and being consistent. What is important is that the information is consistent. If it is being given at which level, it should be the same information, correct information, and very consistent. So we should not be talking about it's only for sexual partners. It should be consistent that even women who are pregnant, once they are virally suppressed, cannot pass it to their babies. It also reduces harm reduction. So the information should be very consistent as it goes out. So back to you, Chair.
So just to chip in something, just building on what Patricia already said, I think education is a barrier, and anything that someone cannot understand, they can never understand it. And I say this because there are lots of people in my grassroots community who have not even gotten the opportunity to have a full grasp of what U equals U is about. So I think we also need that connected effort to take this advocacy down into those far too rich areas where people are most at risk and do not even have the resources that they need to get enlightened and all of that. So I think it is important for us to bridge that knowledge gap, that education gap, by taking advocacy and communication down to our grassroots communities that do not have these services very much often. Yeah, thank you.
Okay, thank you, Emmanuel and Patricia. We move on to the last question, which is, what changes in HIV criminalization laws would you like to see to better reflect the U equals U concept, particularly concerning non-sexual transmission context? That is an open question to everybody. Everybody that would like to speak.
But I need to be able to travel to anywhere without feeling like I am a criminal. I think that's the first thing we should do. All those laws that are not important, that are not being enforced, that are just there for decoration, we should eschew all of them and get on with it. Because people living with HIV are not criminals. We just happen to be living with HIV as a result of whatever happened. But that should be it. Now, science is telling us that we are undetectable, therefore we cannot transmit it. So why do you still hold these restrictions for people living with HIV? So we need to, countries, nations of the world, governments of different countries that still uphold travel restriction for people living with HIV need to revisit these laws and make better provisions for us. And secondly, I also wanted to point out about opening justice channels for people who are also still facing stigma and discrimination to be able to seek redress in court. In Nigeria, we have the anti-HIV and AIDS, the HIV and AIDS anti-discrimination law that was passed in 2014. But ever since that law has been in place, like nobody has actually, like not many people, let me not say nobody because I don't know, not many people have actually gotten justice with that law. So laws are there to shape our society, and we should also be able to use them to the good of the society. So in as much as we don't want to be restricted to travel to any country, we also want you to enforce anti-discrimination laws so that if I get dismissed from my work because I am HIV positive, I should be able to take that employer to court and get justice for it. Because I am undetectable, I pose no risk to anyone. So why should I be dismissed? Why should I be dismissed from opportunities? This is also something that we should also put in place if we want this message of you equals you to transcend and make a great ripple effect in ensuring that people living with HIV are not criminalized. Yeah, thank you so much.
Yeah, thank you. Anyone else?
Patricia here, can I go?
Yeah, okay.
Patricia?
Yeah, please go ahead, Patricia.
I believe that in Kenya, they're using the Sexual Offences Act. The use of Sexual Offences Act. As Elliot was talking, I saw it did bring down issues around maybe biting or spitting. Kenya, people have been arrested for spitting. One was arrested that they did spit in food, and that one was presumed that this person wanted to transmit HIV to the employer. Another one was arrested also because the police were arresting him unlawfully, and he did bite that police officer. So he was thrown in that he wanted to transmit. So how fast can we be able to make sure that the law also understands the science? Because there's a disconnect where we as people using the medications ourselves, the clinicians who are conducting the services, we understand the science faster, yet the law itself is taking quite a while to be able to align itself to the science. So maybe Elliot can be able to give us some light on what do we need to do to make sure that the law aligns itself to the science in terms of criminalization. So back to you, Chair.
Yeah, maybe I jump in there. Yeah, I think it's a really good point. You know, as I said in my presentation, we should set as our ultimate goal repealing all HIV-specific criminal laws. But as we've talked about, criminalization occurs under those general laws as well, like the examples Patricia has pointed out in those cases in Kenya. I think that highlights the need for really clear and strong prosecutorial and policy guidance to be adopted, so that in those countries that do sometimes apply their general laws, we can look to this guidance that says in certain situations, HIV cases should never be brought. For example, if it relates to activity that really carries no risk of transmission, for example, spitting, or only a very negligible risk of transmission in the case of biting, but essentially there's no risk there either. So there's definitely a place for strong prosecutorial guidance that can limit the use of general laws to only those cases that align with the UNAIDS recommendations of intentional transmission. I think we also do have to be realistic that because there are around 80 countries that have HIV-specific criminal laws in place, they're not all going to be repealed overnight. And in some jurisdictions, it will be very difficult to repeal those laws anytime soon. So maybe we need to think about, as advocates, we need to think about what is a realistic goal for the foreseeable future. Perhaps that's reforming those laws and not necessarily repealing those laws, although repeal should be the ultimate aim. So in those situations, then maybe you look to countries like Congo, which I pointed out earlier, which has a whole range of inbuilt safeguards in place in the law, which should also act to significantly limit prosecutions. So why it would be better for Congo not to have that law in place? Realistically, maybe it might not be possible to repeal that law. So if the law is going to exist, then we should look to make sure that they are very explicit in situations that they shouldn't be applied in. And those should relate to the HIV science in relation to transmission risks.
Oh, okay. Thank you, everyone. Thank you. I don't know if Sibongile would like to add something to that, but let's just. Do you have something to
If I
add?
can just chip in something. I do this a lot, but I just always try to find connection with underrepresented communities. So we are talking about you equals you and how that can reduce stigma and all of that. But some people are still unable to attend you equals you because of some criminalizing laws and policies in place that criminalize their existence, such as LGBTQ folks, most especially looking at what is happening in Uganda now. So we have made important strides in HIV prevention and also in eliminating new infections and all of that. But how are we going to ensure that this progress is permanent? How are we going to ensure that everyone is carried along? Because if a community of people are constantly being criminalized and being killed for who they are, they cannot access healthcare services, and they cannot even access antiretroviral therapy for them to even attend undetectable viral load. So how are we going to also reform some of these other laws that have direct connection to you equals you and HIV criminalization? And I'm not asking so that we can think about it, just like an open thought for everyone.
Yeah, Emmanuel, you made a great point. That is a great point, actually. So now, for the purpose of time, I think we're gonna move on to the question, to the Q&A questions. I'm gonna, Catherine, do you have something to say? Or I will just like to pass it to Wilson, Dr. Wilson, to continue with the session. Ooh, okay, please, Marianne, go ahead, please. Unmute yourself and I don't know.
Hi everyone, I am Rian Wambuku and I'm also part of the Young Emerging Leaders. And I'm really happy that you're having this discussion and I'm hoping that all of us are learning in the process. Please also feel free to chat in the chat box if you have any question or any comment or anything that you need clarity on U equals U, because we are here to learn and we are here to demystify the myths and misconceptions around U equals U. So I think from there I will take it back to you so that Dr. Wilson can continue. Thank you.
Thank you, Marianne. Thank you.
Before Dr. Wilson, I wanted to clarify me on the questions that are asked in the inbox. How are you going to reply these questions? Because we are even running out of time.
I don't think there's any question for us not to. There's any reason for us not to respond to the questions. So, hi.
I think there is a question on. It is Veronica. I would like to know. Is seeking clarification on these three areas. Are there specific conditions under which the U equals U principle might not apply? And then secondly, how does the U equals U principle affect the use of PrEP? And then we have finally, what is the scientific evidence supporting U equals U principle? I think that has already been answered by Sibongile. Then
can I just give short answers?
Okay, yeah, please.
Are there specific conditions under which U equals U principle might not apply? When you stop taking your antiretroviral,
okay, yeah,
then it will not apply. You have to consistently remain undetectable for this to work. So if you stop, it's on you. Okay, so how does the U equals U principle affect the use of PrEP? It doesn't affect the use of PrEP. Any sexually active person who is on PrEP can continue taking PrEP as long as they want to continue taking PrEP. And it even increases the prevention strategy that both partners are taking. You, on one hand, you are undetectable, you cannot transmit the virus. And on the other hand, you have a partner who is consistently taking PrEP to prevent viral transmission. So kudos to you both. So you shouldn't stop PrEP because I am undetectable. If you want to continue, that's fine. But the science still remains that I cannot transmit the virus. Yeah, thank you.
Yeah, thank you, Emmanuel, for this clarification. Actually, yeah. So, Dr. Wilson, are you there? I think we are. The time is running out. I don't know if we can keep going. Yeah, Marian, please go. Okay. Yeah, Dr. Wilson, you are here. Please take over. Okay.
No, she can speak.
I don't know. So, all of the attendees, please feel free to raise your hand and ask any question that you have. Just drop it in the chat. And then, yeah, Catherine.
Thank you so much. I think due to time, we'll have to cut this short, and we have gotten the questions from all the panelists, directed to the panelists. And if you're a panelist and you'd like to jump in quick, maybe you can. But for all the attendees of the session, we have taken note of your question and will answer back to you in your emails, if that is okay to the correspondence of time.
Okay, thank you.
Yeah. Unless the panelist has something to quickly add, that is okay. But otherwise, we shall get back to the questions via an email. Yeah.
And then I think we're gonna take a shot, a photo capture.
Enoch, before we end, maybe we can just give one participant who has raised, I don't know if he or she, the hand, so that we don't limit anyone from mentioning anything that they will really like to comment. So Benny, if I'm not wrong, Benny, please unmute your mic and maybe 1 minute.
Thank you. So, as you said, the comment of Charles, he noticed that the community has not the mentality that the HIV can be transmitted when we use ARV. So within Africa, we have some barriers, or I can tell some principles, which means that HIV equals disease. So people don't have that mind that within the process, within the advanced, the scientific advanced, we can even control that pandemic situation. So my question is, within the communication, how can we involve more people to understand that HIV can be as more as disease which can kill many persons? Don't know that you get my question.
I do get your question. Thank you so much for that question. So I don't know if there's any panelist who would really like to respond to that before we end.
I just have one approach, and that approach I tell everyone, we all have a voice, and we can speak in any community, in any space we find ourselves in. So it is also our individual collective effort to ensure that we get that message out there. Are you using your voice? Are you speaking loud enough? Are you communicating to the next person beside you about the message of you equals you? How are you doing it? The more people we talk to, the more we raise awareness. I think that's my only approach to that. Thank you.
Thank you.
That's really good. That's really good. Thank you so much, Emmanuel. And I hope that responds your question, Benny.
Yes, thank you.
Awesome. Thank you so much. Due to time, and I will really want everyone to maybe go on with their evening business or afternoon business. Mine is to say thank you and to appreciate you for joining this call. To not have been till this far without you guys. So we are looking forward to more engagements with you, even for the webinar that will be upcoming. Please be on the lookout on Y Plus Global page. We'll be sharing our next conversation regarding HIV. Thank you. And also on the chat box, we have posted our email address. In case you have any questions or concerns that you need to be addressed, please reach out. We are available to speak to you. So yeah, thank you, and bye everyone.
Before you leave, before you leave, kindly turn on your cameras if you'd like us to take a screenshot. Hello, everybody. You all look so gorgeous. Thank you for joining. Hello.
You're welcome.
So I'm taking a screenshot in 3, 2, and 1. Smile.
Bye.
Okay. Thank you, everybody.
Was that good?
Yeah, I think it was good.
Thank you.
Thank you so much. Have a great day.
Thank you, everyone.
Thank you,
for
everyone.
joining.
For you.
Bye.
Bye-bye.
Thank you. Who are we
Bye,
getting
bye,
that?
bye. Enjoy the rest of your day.
Bye, guys. Bye.
Guys.
So, Catherine, are you ending the session? You are mute.